So I'm Mina Cheng from Hong Kong. I'm a general surgeon with special interest in vascular surgery and trauma. And today I'm very honored to be here to present how we start a REBOA in trauma in Hong Kong. So the indication for REBOA is a preoperative resuscitative procedure for exsanguinating non-compressible torsal hemorrhage. And to start REBOA, we begin with the exsanguinating and mechanically unstable pelvic fractures, not responsive to fluid resuscitation, because this is the procedure with least risk. And I'll explain more later. And as Raj has explained, we have three zones of the aorta. For zone 1, it is from the left subclavian artery to the celiac trunk. For zone 2, it is a no balloon zone. It is from the celiac artery to the lowest renal artery, because the deployment of balloon here will affect the blood flow to the visceral arteries. And for zone 3, it is from the lowest renal artery to the aortic bifurcation. And this is where we put the balloon whenever there is exsanguinating pelvic fractures. So different parts of the world have different protocols in putting in REBOA, but mainly we must bear in mind that we must exclude possible aortic injury on a chest X-ray before using a REBOA. If FAST is positive, we would deploy it in zone 1, but if the FAST is negative and there's only a pelvic fracture, then we would inflate the balloon in zone 3. Similar protocol is present in and is used by the Western Trauma Association. And the history of REBOA actually can be dated back a long time ago, back to 1954 in the USA. And it was used in the pre-endovascular era. And in the endovascular era nowadays, actually, we have been using the aortic balloon a lot in ruptured abdominal aortic aneurysm. And currently, the use of REBOA in trauma, this paper from the USA published in 2011. And what about in Asia? In Asia, Japan has a lot of experience in using REBOA in ruptured abdominal aortic aneurysm, placenta previa percreta, and in trauma. And there have been always comparison between resuscitative thoracotomy and REBOA. And resuscitative thoracotomy is considered more definite, but it involves a new chest wound with a potential chest wall bleeding and hypothermia. As for REBOA, it is less invasive and speedier and adjustable, but we need to perform the common femoral artery puncture, and it can associate with leg ischemia. Some papers regarded REBOA as more beneficial than resuscitative thoracotomy. As for others, they showed no significant difference. The question we always have to ask is, for REBOA patients who will survive and who will benefit, how can we select the patients for REBOA? And from this paper in Japan, we know that the patients who survive with REBOA have a pre-occlusion systolic blood pressure of around 70 millimeter mercury, and with a shorter duration of occlusion of around 30 minutes. In other words, we should put in REBOA timely with the SBP around 70 millimeter mercury and with a shorter occlusion time of around 30 minutes. If we put the REBOA too late, the patient will likely not survive. There's a paper published in JAMA in 2019. It is a paper written by the USA colleagues, and it shows that the REBOA actually does not help. But in closer look at this paper, we would know why there would be more acute kidney injury, more amputation, and higher 24-hour mortality. In those who survived, we found that The systolic blood pressure was 140 millimeter mercury. GC score was 15 against 3 in those who died, and with a head AIS score of 0 against 2 in those who died. And for the REBOA group, the systolic blood pressure was actually 109 millimeter mercury with a GC score of 14. In other words, these patients were just too stable to require REBOA, and this suggested unnecessary REBOA placement in a stable population will lead to more complications, more amputation, and more acute kidney injury. We adopt a team-based approach in starting REBOA. We have a leader, we have a case coordinator, service coordinator, operator, and assistants. We have to prepare all the hardware in the emergency room resuscitation room. We need to have a built-in X-ray machine, a resuscitation stretcher, ultrasound machine with a linear probe, and a REBOA set. In Hong Kong, and I believe in many parts of Asia, we only have the Tokai rescue balloon occlusion catheter. In USA, they have the ER REBOA catheter, which is not available in Hong Kong. We also need an 8 French or 7 French arterial sheath set. For us, we prefer to have an 8 French arterial sheath set because the balloon is of 7 French in size. After inflation of the balloon, and it is quite difficult to remove because the balloon cannot shrink back into the pre-inflation size. Nowadays, there's always advocation of AABCDE instead of just ABCDE in the primary survey. We add another A for arterial access. The advantages of early arterial access is that we can always upsize to have a REBOA. We can use it as an arterial line. We can have early intervention radiology help, and we can use it for blood sampling. And delayed arterial access can be a catastrophe because the patient can, and the artery can be collapsed and not palpable. And even the patient can develop cardiac arrest and or have a hematoma around the where you want to have the arterial access. For the steps of having REBOA, it will be done under aseptic technique. We prepare and drape the groin. Depending on whether the patient is conscious or not, we will inject local anesthesia. But many a time the patient is already not conscious, so this is not needed. And we would visualize the femoral bifurcation with the ultrasound, and then we will puncture it. Under a Seldinger technique, we will insert an 8 French or 7 French sheath, and then we will insert a guide wire. We see the guide wire in the aorta with ultrasound. Many a time we will confirm it with the portable X-ray simultaneously. We will measure the length of the balloon inside of the catheter inside the body. It will be around 30 to 35 centimeter for a zone 3 occlusion. That is from the groin to the umbilicus. This is used for perifracture. And it will be around 50 to 55 centimeter for zone 1 occlusion. We would measure from the groin to the second rib. We'll insert the balloon catheter over the guide wire and exchange to the stellate. We inflate the balloon with a sterile saline solution in 20 ml syringe. We can always consider partial occlusion in zone 1 in order to reduce the visceral ischemia. The blood pressure will increase rapidly after inflation of the balloon, and we always look at the blood pressure change. We don't need to fully inflate the balloon to achieve a good REBOA. We will then secure the balloon with a tape or suture. If the artery is small in size, we can always insert a small sheath then upsize. We can use an 80 gauge needle or a 4 to 5 French sheath and then upsize with a 035 guide wire. Do not hesitate to cut down in difficult patients, especially those obese patients. It may be difficult in elderly tortuous aorta because of the calcification, stenosis, and tortuosity. For the potential complications of REBOA, it include common femoral artery access complications, wrong position of the balloon, rupture or dissection of the aorta during inflation of the balloon, thrombus at sheath and catheter during removal of the balloon. For common femoral artery access complications, they include dissection, pseudoaneurysm, massive hematoma, retroperitoneal hematoma, thromboembolism, and leg ischemia. For the complications, for lower limb amputation, it was reported as high as 21%. However, this paper, they use mainly those older aortic balloons of French 10 to 12 French size. And nowadays, we have a small profile REBOA that is of 7 French size. The left one is a Tokai balloon, and the blue one is the ER REBOA balloon. There are fewer complications with smaller sheaths. The fasciotomy rate, amputation rate, and need for percutaneous angioplasty was reported to be 0, where after we used the smaller French size balloons. For the inflation of the balloon, we must take into account the aortic diameter. We must consider the patient's age and atherosclerotic state, and whether we inflate it in zone 1 or zone 3. There is always a migration problem, especially with a small profile REBOA. So we need to tape or suture the catheter at the groin area. For deflation of the balloon, patience is the essence. It must be done in a slow and spiral manner. We need to liaise with the anesthetist before deflation of the balloon because of potential drop in blood pressure after deflation of the balloon. Do not pull out with force, especially when we use a 7 French sheath for a 7 French Tokai balloon. There were reports about a broken balloon after forceful pulling out of the catheter. For the thromboembolism, the clots can be above the balloon in aorta, at the iliac and femoral arteries, or at the distal lower limb arteries. There can be sheath thrombus, and there is always a role of embolectomy and angiography. So support from vascular surgeons are sometimes needed. So who can place REBOA overseas? Mainly, REBOA are placed by surgeons and emergency physicians. But it can be also inserted by pre-hospital personnel, military personnel, or air ambulances. There are many courses overseas for teaching of REBOA. We have the Japan course and the best course in USA. This is a photo where Dr. Lee Kinyan, my mentor, and I went to Houston in USA to attend the best course before bringing REBOA back to Hong Kong. And for the training, for the local training plan in Hong Kong, we start with a virtual reality simulation using a 3D vessel model and virtual thoracoscopy. And then we use a live animal lab in our advanced surgical trauma course. We also have human cadaveric dissection to familiarize with the groin arteries and groin dissection. And then we have assistance in procedures requiring vascular access. We carried out our first REBOA workshop in Queen Elizabeth Hospital in January 2019. We practiced the vascular access with danger technique under ultrasound guidance using a gel model. And then for the second station, we had the 3D vessel model, and then we can practice insertion of the balloon. For the third station, we have the virtual fluoroscopy. using the Mantis Vascular Trauma Management Procedural Training. So this is a computer which can simulate different occasions. After all these simulations, we have the hands-on practice. This patient is one who would undergo endovascular repair of AAA, of abdominal aortic aneurysm. And then our colleague, Dr. Ho Hiu Fai, from Accident and Emergency Department, came to our hybrid theater to practice the puncture and self-danger technique of insertion of the sheath. And in cases of percutaneous angioplasty of the iliac arteries, we also invite them to come to have a hands-on practice. Before we set up a REBOA call, we need to set up algorithm, flow, and protocol. And we must foresee any complications throughout the whole process and after procedure. This is a management algorithm for exsanguinating pelvic fractures. Initially, we only have the 3-in-1 pelvic damage protocol, which include the external fixation, angioembolization, and pelvic packing. But after introduction of REBOA, in those who are unstable, we would insert a REBOA. We will insert a REBOA in patients with a systolic blood pressure less than 70 millimeter mercury, with a normal chest X-ray, unstable pelvic fracture, and we would document the lower limb pulse status, especially after the procedure. We need to modify our pelvic binder because we need to cut out a hole at the groin area for insertion of the sheath. This is a part of the protocol for fast negative and open book fracture with a systolic blood pressure less than 70 millimeter mercury. In the emergency room phase, we prepared the Tokai balloon. And then, as mentioned before, we would measure it, and then we put in guide wire, confirm with X-ray, and then we insert the balloon, and then we confirm the position with X-ray again to make sure that the balloon is above the umbilicus. And then we exchange the guide wire with a metal stylet, inflate the balloon, and then record the blood pressure before and after inflation of the balloon. We record the time of inflation and mark the time with a stopwatch. We record the volume instilled into the balloon and tape the balloon shaft on patient's thigh. We then immediately liaise with the operation theater and the anesthetist and send the patients to the operation theater as soon as possible. At the same time, we activate the massive transfusion protocol, and we will have the point of care test at the emergency room. And we take into caution that zone 1 balloon should not be inflated more than 30 minutes, and zone 3 balloon should not be inflated more than 2 hours. And we would also be careful of any tortuosity, calcification, and stenosis of the aorta. For fast positive with an open book pelvic fracture and systolic blood pressure less than 70 millimeter mercury, we aim at zone 1 aorta. But for this part, this is implemented at the later stage after we familiarize with the insertion of the REBOA at the zone 3, because it is associated with more complications due to the impair of blood flow to the visceral arteries. And then we carry out our pelvic fracture 3-in-1 protocol in the operation theater. After external fixation and pelvic packing, we would slowly deflate the balloon, and then the balloon can be always inflated after confirmation of the space. And then after the procedure, we can remove the balloon, and the radiologist can perform angioembolization with the same sheath. So they do not need to reinsert the sheath again. And after the whole procedure, the sheath is left in situ for further angioembolization if needed, or close monitoring in ICU. And as I mentioned, lower limb pulse monitoring is always needed on table after operation, and we need to also monitor it continuously in the ICU. In the ICU phase, in case the lower limb pulse is absent, we need immediate vascular consultation for review. And after stabilization of the patient, we will proceed to have whole body CT scan plus or minus CT of the lower limbs. An apron sheath should be removed with percutaneous closure device, for example, ProGlide in ICU or the operation theater in subsequent OT, because if we just carry out manual compression after the sheath removal, there's a high chance of hematoma formation. Ladies and gentlemen, to conclude, REBOA is a potentially life-saving procedure. It is a useful adjunct to temporize hemorrhage. It is a tool in our kit to be used as an adjunct in resuscitation. It can be used in a wide variety of clinical scenarios. It may replace emergency department thoracotomy for selected indications only. Caution must be exercised, and do seek for help if needed. Thank you very much.